of course, with Nivolumab, the whole scenario of the side effects is totally different. Catherine was kind enough to tell us all about the concern that she has from her very important perspective, which is the liver. But what are the other things that you'll watch for when you're dealing with Nivolumab?
Okay. So if I start with the data from the trial itself, the rate of grade 3 and 4 treatment-related adverse events was really around 20%. And most of them, if you look at the details, were laboratory aberrations. There were elevations in AST, ALT, asymptomatic elevations of amylase, lipase. There was a small frequency of diarrhea and rash that are grade 3. Most of those, actually, most of the other side effects were grade 1 and 2. So now the challenge is with the AST, ALT elevations. Are these because of the underlying liver disease, the cancer, or is it really an autoimmune process from the drug? And sometimes that's difficult to call. So there's a lot of physician judgment involved. I can say that in the HCC study, we did not see a higher frequency of autoimmune complications, including autoimmune hepatitis, more than seen in other tumor types. That much we can say. As you know, all these clinical trials with checkpoint inhibitors have already parameters for initiation of steroids upon the onset of certain toxicities.
So let me go a little bit more practical. Diarrhea, tell us a little bit more about that.
So again, normally with diarrhea, if it's grade 1, just symptomatic management, the usage of loperamide or Imodium is certainly appropriate, supportive care. The minute you start getting to grade 2 that's persistent, you start worrying a little bit more about an autoimmune process that's more like a colitis. And at that point, there are recommendations actually to pause the dosing and consider starting steroids. The challenge with steroids is that the taper has to be slow. Usually the recommendation is that the taper happens over a period of a month in order to avoid a flare of the autoimmune complication.
And what about rashes?
So rashes are actually one of the more common toxicities. They frequently respond to just topical steroids. The rare instances where patients had to have systemic steroids are for grade 3 and above rashes that did not respond to topical therapy, and those were quite rare. So it's mostly about just topical therapy that would be
and do you recommend, Anthony, at all for patients to have their thyroid function checked on regular basis, and how regular is regular?
Sure. I mean, again, the trials were quite aggressive in checking thyroid function at very regular intervals. I think a baseline evaluation of thyroid function is important, so one can have a reference point. And then every 2 to 3 months, I think, in clinical practice would be important, because sometimes the laboratory changes precede the symptoms, and you want to catch a new onset hypothyroidism or hyperthyroidism before it becomes symptomatic.
Fair enough, fair enough. And Catherine, just from your perspective as a hepatologist, does it bother you or not at all, or in between, in regard to giving steroids for patients with HCC who are on active therapy like checkpoint inhibitors?
So before I get to that question, I do just want to make a comment about the diarrhea. For both the regorafenib, sorafenib, and the checkpoint inhibitors, don't forget to check and make sure that it is actually related to this therapy and you're not missing C. diff or some other infection. And we've had some patients that got treated with steroids but didn't get checked and actually had C. diff. So just be careful to check that. It's actually interesting when you look at the data and of the side effect management. When the patients got steroids, they actually didn't seem to have any effect on the response to the drug. And so you have to, of course, monitor for steroid side effects, and we've had patients have terrible insomnia and high blood sugars and things like that. But that doesn't necessarily mean if you're giving a checkpoint inhibitor and now you're blocking it with steroids that you're not going to still see a good effect for the cancer.
So fair enough, and that's very important for our colleagues, is that it's totally appropriate and okay to give the steroids to control the symptoms, and it will not really reduce on the potential for the therapy to work.